Okay. So, wait a little bit for starting the recording. So
Yes.
wait a little bit. Otherwise, everything is what to
Settle
say.
down.
Yes.
That's good.
No. It's good to see if I'm sending at the right screen. Share screen. No, this one. Share. So I'm starting to share now so they can join if they're.
Ooh, there are people sitting
Yeah.
on the screens. Fine.
See, I'll just check it's sending out properly.
Yeah. Thank you. And
I can't find anything on this new homepage. It's so bad. I can't even find it.
oh, Madame Ashima, bonjour, Madame.
Sure.
Bonjour, mon cher. How are you?
Good. Came to listen to you talk.
Oh my God.
I'm going to sit here.
Yes, first row.
Yes.
The VIP places.
Yes, of course.
They're just given to very, very good friends, you
Yeah,
know.
exactly. So I have already put myself in that category. No, no.
You're welcome to do so.
Those things.
Good morning.
Wait.
Okay. At least I had a calm night.
What?
Yeah. One phone call yesterday evening. Some silly patient that tried to kill herself with alcohol and some pills
Some blues?
did not succeed and then wanted to go home. So we sent her home.
Wait, alcohol and pills, like the
Yes.
sugar water.
No, the pills.
Oh, the pills.
Some
Oh,
pills she had at home, like sober and
that's sad.
yeah.
Sober is not.
She wasn't even tired,
That is.
so everybody was disappointed, and then we sent her home.
Mm.
Well, she wanted to go home. Go home.
Nikki's also here. She's working on it from 12, but she's like, oh, come to listen to Thomas.
She can do this from at home. She can. It's online.
She told me
If you
it
find it.
That is lovely. Who's going to Violet?
I never know.
Oh, you got
Thank you.
Yeah.
Good afternoon. Did it?
Yeah, from started on Monday.
Yeah, okay.
Yeah. Brieden said, "Minimal stop them. Long katima."
Okay.
Yeah.
Ekkert svar.
No, I have my outfit ready, but it took so long.
Okay.
It was just like, today, no, today. I would call them, they would pretend to type something and like,
Computer says no.
I'm telling you, Thomas, so on the day I got my permit last Friday, so I had called the lady because I got an email from Yfirlæknir. They were like, so you have fulfilled all of the requirements for the application, and now we've sent it to Vinnumala.
Okay.
So I was like, okay, that should take maybe 4 or 5 days. So I called them on Friday, and Catherine has already sent all my files to the Vinnumala because they have everything.
Okay.
And I asked the lady, I was like, hey, so this is the story, and we have sent all the files. Like, what is the next step? What is taking time? Like, why haven't testing called it? Oh, she was like, it's just a waiting game now. And I was like, can you check if you have received the files? Because then this can be done today. And I heard her type on the keyboard. And she was like, oh, no, nothing has come today, and it won't happen today. I was like, fine, whatever. I put the phone down. Half an hour later, my permit got accepted. So I told everyone, I was like, if you call Yfirlæknir and they type, they are lying to you. They are liars. They are just.
Computer says no.
They have a keyboard that's not even clicked attached to the computer. And you know those especially
I think
noisy
it's
ones.
a fake keyboard.
Yeah,
It's not connected to the computer.
Yeah, it's
They're just, or maybe it's something that just makes the noise on the keyboard.
Like, you know,
Click, 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 click,
Yeah.
click, click, click.
yeah, I checked, nothing is there. I
Yo.
was like, okay.
It's 30 minutes later, it was all confirmed. Yo.
It's like, these guys are fucking ridiculous. And I paid them 70,000 krona for it to come in 30 days. It took 8 weeks.
17,000, 70.
70. There's a very good reason I'm sitting here broke as fuck. I have no money, but I have 15,000 so much, so I have some money. Hi.
Oh God.
Hello.
Hey.
Life is hard.
Life is shit.
Like literally, I paid them so much of cash, and you know what? You know what's even funnier? My permit is valid till the 31st of December.
Oh, I heard you're working from 12. What are you doing here? What the hell?
To attend your lecture, of course.
You could have done this from at home.
No, she wanted to see you.
You don't even have to sit
I'm
here.
here for moral support. She's also taking the front.
It's so nice to have you here.
Nice shoe.
What's that, the drugs?
Coffee. Yes, all the drugs. Coffee with cocaine. It's with vanilla.
But it was yours. No,
It's yours.
oh, darling.
If I had 3 hands, I would have brought 3. But I only had 2. Besides, you need it. Exactly. She's guilt-rendered. I've been here longer. That has to leave it.
Good day.
Okay.
Yo. Tak, it's nothing, no, it's nothing. It's just,
Okay.
it's something we see quite often in old age psychiatry,
Okay, okay.
and I thought it could be interesting for the children.
Já, já. Ég byrja, svo þarf ég að fara að fund, þannig við sjáum. Það er gaman. Já. Especially if you're doing the test.
Do you have one? You give me the sign. Yeah, it was.
You did manage to stop.
I think I should stay like this. Is that okay?
No, then, well, I see you, but they can see you.
It's enough if you see me. Nobody else has.
You need to speak up a little.
You know, I'm type of a shy guy, you know.
Oh, yeah.
Yeah, you know me like this. Yeah,
You're the most introverted person.
You know, psychiatry, you always have to follow him. Follow the words of what you feel. The lines in the door. You see the lines? Yeah. Oh, shit.
But you could scoot your chair. You would fit within the lines.
It has to do something with the.
Now it's like me.
You can just see parts of my hair. It's not really funny. I should never have taken this lecture. You can do what you want. It's not important to see me, you know.
Thomas með efni hérna Pseudodementia.
Yo. I feel it. So I was told to stand here between the lines. I hate being exposed. Good morning, dear colleagues. Thank you that so many of you arrived at this early time of the day. So as some of you may know, that I am not just specialized in psychiatry, but also in old age psychiatry. I thought something of the field of old age psychiatry could possibly be interesting for you. And I held this lecture some weeks ago in Germany in my former clinic about pseudodementia, and I thought that it could possibly be helpful, especially for the junior doctors of our hospital as well. So it's pseudodementia when diseases disguise themselves as dementia, but are not. So where does the word pseudo or pseudo come from? It's from the Greek words of pseudes, which means wrong or lying, or pseudos, which means illusion or lie. So that means wherever the word pseudo is put in front, means something is wrong, fake, or faulty. So if we combine pseudo to dementia, this means that a pseudodementia is a condition that simulates the typical symptoms of a dementia without being one, without being a real organic dementia. Still masses flowing in, masses of people. So, but what do we mean by a real or organic dementia? First, we have degenerative brain changes that are of various locations and varying degrees that lead to typical and regular functional failures. I brought some pictures. Hopefully the colleagues from radiology are not here, because then I fail. What could you imagine this is? Which kind of dementia could this be? If there are any radiologists here, keep quiet. No. This is the typical Alzheimer's disease. What is this? Yes. This was the easy one. What is this? The third big group of dementia. Vascular. Perfect. Who was this? Ever worked in psychiatry? Ever worked in psychiatry? Why not? Oh my God. This is a little bit more difficult and more rare. What could it be? It's Creutzfeldt-Jakob. I think I have one more. No. Okay. So, pseudodementia is very controversially discussed. There is a controversial discussion how often this is. And if you read studies, it's told to be between 1% and 30% of all the patients that come in with like some kind of dementia. But also the construct itself of, so the question if a pseudodementia really exists or not is very controversially discussed. And this is a discussion that is going on for more than 100 years now. And I will show you some papers and some studies that started in Germany in the last 2 centuries ago. So, what the typical symptoms do we have? People have difficulty concentrating. People have memory disorders. We have to keep in mind it's still something dementia. Less often, but possible, orientation problems. Very often depressive symptoms, and the classical depression is sadness, loss of motivation, social withdrawal, sleep disorders, and loss of appetite. But all of this also happens at the beginning of a real dementia. So how can we differentiate between a real dementia and a pseudodementia? And possibly what else? Can you imagine other psychiatric or other diseases that are also in the range of this? Depression, right? And welcome, brother Mataka. Delirium. Yeah. So we have a broad spectrum of disorders that all look the same, but have to be carefully differentiated because the treatment is different and the prognosis is different. So we are going back. Germany at the age of 1898. There were some famous psychiatrists. Maybe you have heard about the name of Wernicke. He described the encephalopathia with alcohol. So in 1908 and 1903, there was a Ganser syndrome described. And also Nissel and Jung in 1902 and Bonhoeffer in 1911 were talking about a special condition that was described for the very first time. And without using the word pseudodementia, we all think today that this was meant by them. At that time, you know, it was the time of psychoanalysis coming up with Sigmund Freud. And so many of the diseases of symptoms that could not be explained were somehow put in the direction of something hysterical. And what was written in that year or later on was that that there was a specific hysterical twilight state characterized by talking past, amnesia, and hysterical stigmata, and in which trauma was assumed to be the cause. So there was a clear predecessor, a trauma that caused this state of whatever it is. So the first time in 1915, there was a not so famous guy, Dr. Bieling, who for the first time used the word of pseudodementia, in German, pseudodemens. And this is a part of the article, and I have a copy of this, the original article of 1915, and I translated it into English because the German is quite old-fashioned. So what is written there? This condition of pseudodementia is characterized by a more or less pronounced change in consciousness, as well as by changing symptoms, which often coincide with so-called hysterical stigmas. These include hyperalgesia and analgesia, but also sensory illusions. Knowledge that the patient definitely possesses or has possessed is lost, or, like questions of the simplest kind, is either not answered at all, or the patient talks past it. For example, he reacts to it in a wrong way, which shows that he has actually understood the question and knows the right answer. On the other hand, from a diagnostic point of view, it is particularly important that organic diseases, even of a more serious nature, can be completely hidden and unrecognizable by the psychogenic symptoms so that they escape the examiner. The patient's subjective complaints usually do not receive the attention they deserve because of the exaggerated manner in which they are expressed. However, since the detection of organic diseases or the organic changes is not only important for the question of compensation for accident patients and for the sanity of prisoners, these studies were made with accident people that wanted to have a pension. So this is important for you to know for the context. However, since the detection of organic changes is not only important for the question of compensation for accident patients and for the sanity of prisoners, but can also be a starting point for therapeutic measures. The diagnosis is not taken into account when assessing such patients of hysterical pseudodementia, but one will have to try whether it is possible to use objective methods to detect any organic changes that can cause complaints that the patients express. So they thought and were on the right track that some organic failure or some organic things are leading to pseudodementia. I think, therefore, this is 108 years ago. They are very forward thinking. So, what possible causes do we have? What could you imagine for pseudodementia? Trauma. Sorry? Yes. Yes. Yeah. Perfect. Yes. So many. Never think that pseudodementia is something for old people. It can also occur in younger. Most important thing in medicine and in old age psychiatry is the medication itself. Malnutrition and vitamin deficiency, dehydration, especially in the elderly, somatic diseases, nearly everything, cancer, infectious diseases, chronic liver and kidney diseases, and metabolic diseases, withdrawal symptoms and addiction, traumatic brain injuries, and so many more. So let us start with the first one. And I brought you a case report. Both case reports I present to you today are from my former clinic or from my time having an old practice in Germany. So case report number one. A 70-year-old man presented with symptoms that had existed for 5 months. The man was not longer able to follow simple newspaper articles or television programs, and he was unable to drive a car because he no longer knew familiar routes and got lost. In addition, the man complained of tiredness and was afraid of being alone. Family members reported a significant social withdrawal. The man hardly left the house and required constant help and support from his wife, even in smaller everyday things. The patient also developed increasing psychomotor and inner restlessness. The family doctor prescribed lorazepam, Temesta, which led to an increase of restlessness, so that it has to be discontinued. After discontinuation, the restlessness subsided again, but quick irritability maintained. The patient's psychiatric history revealed a first major depressive episode 3 years ago. With medication and psychotherapy, the depression disappeared within 3 months and never reoccurred thereafter. The antidepressants were discontinued after 1 year of treatment. 10 years before this first depressive episode, the patient had been successfully treated with zolpidem and low-dose lorazepam for some sleep disorder, anxiety, and somatic complaints. The additional medical history included well-controlled hypertension, elevated cholesterol, and sleep apnea, which was successfully treated with a CPAP machine. The patient was highly educated and had a high level of verbal and practical intelligence. So what are your suspected diagnoses and what tests would you do? Questions especially for the junior doctors. Yeah, this is what most people do, nothing. So first, blood testing. Yeah, perfect. So blood test, everything was normal, nothing special. Second thing in psychiatry. What would we do without our colleagues from radiology? CT or MRI from the head? MRI of the head showed minimal hippocampal atrophy, slightly accentuated to the left, and slight enlargement of the temporal and coronal sulci, no signs of infarction. So quite normal for a 70-year-old. Next. Yfirlæknir consulted a neurologist. The patient was sent to a neurologist. Result of the neurological consultation: depression, disturbed day-night rhythm, psychomotor and inner restlessness, significant limitations in everyday functions, memory, linguistic skills, and executive functions. Diagnosis by the neurologist: early dementia of Alzheimer's type, worsened by the occurrence of depression. The neurologist recommended rivastigmine, it's excellent anti-dementive medication, as an anti-dementia drug, stopped the therapy with the antidepressive medication that had just been started by the family doctor because of possible anticholinergic side effect, and switched the antidepressant therapy to mirtazapine, Miron. Somebody was not very happy with that, because the patient was then sent to a neuropsychological consultation. And the result was that the neuropsychologist contradicted this assessment, and after extended testing, only diagnosed severe depression, but no dementia symptoms. So this went back to the first neurologist, and the neurologist said, no, I am the one who is right. The neuropsychologist is wrong. So what do, at least in Germany? You send the patient to the second neuropsychologist. He does the same and is coming to the same conclusion as the first neuropsychologist, telling this is just a depression and no dementia. So the psychiatrist now made another testing and asked the family. And another interesting aspect came to light when the cause of the symptoms was examined again in particular detail. The cognitive problems obviously seemed to become noticeable when the patient was prescribed simvastatin for his cholesterol. Although the specialist in internal medicine interviewed saw no reason to believe that the simvastatin had any influence on the cognition, the drug was discontinued. A week later, the patient was able to read the newspaper and to watch television again, but all the other symptoms remained. And then the patient was sent to us. What did we do? We believed the neuropsychologist. We stopped rivastigmine, and we were treating the patients according to the guidelines, in this case with a mixture of duloxetine, mirtazapine, and a low dose of aripiprazole, because he had some delusional thinking. And within several weeks, all dementia symptoms were gone and the patient was fine. So there was no sign of dementia. This is the typical case of pseudodementia in a case of severe depression. And it was good to see that the second neuropsychologist confirmed the first one and was not impressed by what the neurologist said, because the neurologist simply was on a completely wrong track. So this patient could be cured with a simple guideline treatment because of severe depression. So what are our conclusions out of this case report? Always think the impossible. And even though 700 specialists tell you something, it must not be right. Second, if you are in doubt, get a double opinion. If it's a second one or a third one, it's worth it. Ask carefully, look carefully. And something my students and the junior doctors will always hear from me: question yourself as a doctor. Did you really ask the right questions? Did you really do everything that is needed? Because mostly it's not. So this is the German version. This is the English one. So how can we differentiate between a depression and a dementia? So the behavior of the patients is different. Demented patients normally trivialize their cognitive performance losses and try to compensate them. Depressed people normally complain about their cognitive impairment or talk about stupefaction, in German Verblödung. Demented people blame others, are disorientated mostly, oft from the beginning. We often see a restlessness, mostly at night, and they mostly overestimate themselves in what they are able to do. And the complete opposite is depressed people. They normally talk themselves down. They often feel guilty. They often feel like they fail everything. They have insomnia, but mostly without the restlessness that people with dementia have. And which is a very important thing is that depressed people, they have no disorientation. But you have to ask carefully, of course. And if you have a mixture, you can also have a mixture of depression and dementia. All these symptoms, of course, can mix up, and then it gets even more difficult. And if you have the biggest problem, you have a demented patient with depression and with delirium, it's even worse to see where the lines between all these diseases are. So, certain medications. I have a case report that is very typical for the clinic I was working in before. I have a line over it. It says, "Why too many cooks ruin the food?" A 72-year-old man presented to the consultation with the following symptoms: lack of drive, memory problems, insomnia, restlessness, internal and psychomotor, tremor, and difficulty walking. What are your suspected diagnoses, and what would you like to know? Careful, it's a trap. So if you hear restlessness, tremor, and difficulty walking, what are you thinking of? Parkinson's, of course. So medical history. The patient sought medical treatment with a suspected diagnosis of depression. In the end, after a long way, before this patient ended up in my clinic, in the end, in addition to depression, the papers also showed progressive dementia, Parkinson's disease, and a delusional disorder. How could it come to this? So initially, the patient was treated for suspected depression with sertraline 50 milligrams, which had no effect. Sertraline was discontinued, also because the patient's cognitive abilities were reduced. A subsequent diagnosis of dementia without any testing, just based on clinical information, and not by a psychiatric specialist, but by someone, was prescribed donepezil, a second anti-dementia medication, and later supplemented with memantine. So if there is a dementia, the treatment with rivastigmine or donepezil and memantine is state-of-the-art. So this patient got a state-of-the-art treatment of dementia he never had. This combination therapy of donepezil and memantine led to the appearance of hallucinations, which were treated by doctors with paliperidone as an antipsychotic, because they were interpreted as an expression of delusional or psychotic disorder. Under paliperidone, additional movement disorders occurred, oh wonder, especially limited mobility of the extremities, so that Parkinson's disease was also suspected, also only on the basis of clinical information and without any diagnostics of a neurologist. And then somebody started the treatment with L-dopamine, amantadine, and ropinirole. So the patient showed up in our clinic with diagnosis of depression, progressive dementia, a Parkinson's disease, and a delusional disorder, and brought a bag of medication. What would you do? What did we do? Yes. So it was no surprise that this patient was increased in his physical and his mental condition with all these. So what did we do? We just stopped the medication. Of course, we had to be careful. You cannot just stop everything at once. So what we did is we stopped all psychiatric medication in a period of 3 weeks, replaced them with selegiline. It's a very special antidepressive medication, which is a reserved medication in Germany. And oh wonder, within 8 weeks, all symptoms disappeared completely. So no depression left, but this patient never had a dementia. He never had a Parkinson's disease, and he never had a delusional disorder. And everything we saw were just side effects of wrong diagnostics or wrong medication. And it's very unsurprisingly that a patient at his age taking paliperidone could possibly get some motor side effects and increased mobility. But nobody thought of this. So again, what are our conclusions out of this case? My good advice to every patient, never believe your doctor. At least don't believe everything. Second, polypharmacy, especially in the elderly people, is highly dangerous to cause more problems than the medication solves. And again, as a doctor, ask carefully, look carefully. All this trouble the patient had, it could have been avoided if at least some doctor would have been consulted, a specialist at least. And again, question yourself as a doctor. Latest, when the paliperidone led to a decrease of mobility, somebody should have thought into the right direction and not telling people it's a Parkinson's disease. So it's German, I'm sorry, but most of you can read it because it's the same in Icelandic and in English as well. So this is the list of medication that can cause pseudodementia or symptoms of pseudodementia. And if you look carefully, it is nearly everything. Starting from benzodiazepines, which are quite famous in psychiatry in other parts of this clinic, but of course, pain medication, Parkinson's medication itself, many medications from the internal medicine, like beta blockers or any heart medication. So antibiotic treatment is very famous to cause pseudodementia. So when you see this list, we as physicians always have to be careful with everything we do, because everything can cause something that ends up in psychiatry. Just to warn you. So malnutrition. This is an easy question for you, but of course, I would like to ask it. There is one vitamin that... Yes. The most important vitamin in psychiatry is the vitamin B12. Because it is important for the formation of myelin sheds, so-called insulation of nerves. It is involved in the formation of neurotransmitters. And if there is a mistake, I just see it. It must be in the absence of correct transmission. I'm sorry, of information. Dementia failures appear. It's storage in the liver. You know that. And there can be different reasons for deficiency. You all know this, but it's maybe important for the junior doctors. So, but there are two different vitamins that are important. I heard them today. Very important is folic acid or vitamin B9, and of course vitamin D. So these are the three most important vitamins for psychiatry. And this is the reason why we generally test vitamin B12 in every patient that is coming to us as a primary blood test, because a deficiency in vitamin B12 can cause a lot of psychiatric problems. So dehydration. Yeah, I think this is nothing we have to emphasize here. You have to be careful about electrolyte imbalances, especially hypernatremia. Everybody working in medicine knows that. So next is the very difficult differentiation between a delirium and a dementia. So, of course, you can read it by yourself, but I would like to see there are some special things that I have to emphasize. A delirium mostly starts abrupt, and you can mostly name a certain date or time when it starts, which is simply impossible with dementia, because people are mostly sliding into dementia. If you have a patient that is suspected of dementia that started abrupt, it's mostly pseudodementia. So there is the differentiation between these two. Delirium always is an acute disease that lasts days to months, rarely later, and dementia is always a chronic disease with years of progression. The delirium is often, but not always, completely reversible. You have an early disorientation, which occurs late in the people with dementia. The delirium is characteristically with fluctuations, which can be within seconds or minutes. Mostly the dementia is very stable. The consciousness in delirium is mostly changing, and it's not in dementia. Delirium can have, or mostly has, an extremely short attention span, which is not typical for dementia. And you have this disturbed sleep-wake rhythm. In delirium, it's mostly with hourly variations, and the shift of day-night rhythm in the dementia people is mostly very, very late in the course of the disease. So this is, of course, not everything. And you see, if you now add this list to the first list, the differentiation between depression and dementia, it gets even more complicated. And the bad thing is that you can have all three diagnoses, and then it really gets complicated. So we talked about somatic diseases that can cause pseudodementia. Easy to see. Brain tumors. What could this be? Infectious brain diseases. And this is a little bit more rare. I had to really search a long time to find these. These are chronic renal and hepatic encephalopathy. So I don't know if these pictures, if these images are really typical, but all these changes in brain can cause pseudodementia, of course, as well. So why do these diseases cause symptoms of pseudodementia? Because everything that is going on in the brain, of course, has an influence on information processes. Some of the diseases and tumors can produce psychoactive substances themselves. Hormonal processes are influenced. Yeah, we can read so. This is something I would again like to emphasize, because we just had a patient on our psychiatric ward that was prior, before the patient came to us, on Yfirlæknir in this house. And there were no examinations of the thyroid hormones done. And this patient had a massive hypothyroidism. She had a TSH of 20. So please keep in mind, if you see any patient that seems to be somehow psychiatric, please think of so basic things like thyroid hormones. I don't say that this patient was psychiatric because of these thyroid problems, but it's simply the examination is not done until you also have the thyroid hormones. And these hormones were really highly wrong in this patient. So, and this is just for the rest. Of course, you know that also withdrawal symptoms in patients with an addiction can show signs of a dementia. And this is not new traumatic brain injuries. So what I wanted to tell you today is, and I hope I chose two very important and very interesting case reports. My former job in Germany was head of a clinic that was just dealing with old age psychiatry. So I had patients from 65 up. And I could have told you 100 case reports of people coming to us just because of a mistreatment or a wrong diagnostic outside the hospital. And especially the polypharmacia and diagnosis set by non-specialists. I don't say that a non-specialist is not able to do a proper diagnosis, but there is a reason why there are specialists in neurology, psychiatry, and why, at least in Germany, there is also a specialist in old age psychiatry. It does make sense. Yeah. And I had people coming in, elderly ladies, that brought a big bag and a suitcase full of medication they took every day. So the maximum I've seen was an elderly woman at the age somewhere in the 70s. She came to us with a diagnosis of pseudodementia, and she brought 25 different medications she was taking every day. 25. I don't know why this woman had breakfast. She left our clinic with 9 medications. There were 7 internal medications, so internal medicine medications, and 2 psychiatric, and she was fine. No sign of dementia, nothing. I don't know if it's the same in Iceland, because you have a control system. You can have a look into Saga and know which doctor prescribed which medication. This is not possible in Germany. You have to phone each doctor and ask, what medication did you choose? So, and no doctor knows about the medication. If the patient is not carrying a medication list, a legal list, and you don't know about the medication, it's your fault. It's your trouble. And mostly it's like, you see the patient as a doctor in Germany, you make a diagnosis, you give a medication without knowing which other medication the patient takes. The result is that there are patients taking 25 medications, ending up in psychiatry because they are somehow weird. Oh, wonder. And this is what I want to say. It's different in Iceland, and I'm very grateful for that we have more control mechanisms here about the medication. But you never know what the patient really is taking, so ask. Are there any questions about pseudodementia? It is very difficult to differentiate between dementia, pseudodementia, delirium, and depression. And I must agree, it's always also us as the specialists, we are not always able to differentiate. You just have to be aware of possible diagnostics.
Sure.
Yes.
Then from 1 to 30%.
Yes.
What treatment do you use?
So from my professional experience, I would be on the lower side. I think 30% is way too much. If you read the studies, I'm not quite sure if they somehow mixed up delirium and pseudodementia. So from my professional life, I would say about 10 to 15% of the people coming into my clinic had really had a pseudodementia. Roundabout.
Thank you very much.
But it's difficult to see.
Thank you for me and team. Of course, this was very enlightening.
I thought hopefully it was not too basic, because
No, it's beautiful. And a little comment. Alois Alzheimer, he wrote this PhD thesis on the earwax.
yes.
So
Thank you for this.
It's a little calm.
Yes.
But anyway, regarding this pseudodementia, use of alcohol. You mentioned that. This is an increasing worries.
Yeah.
In elderlies, at least in Iceland.
It's always difficult to put everything in a lecture of 45 minutes. You're absolutely right. So in Germany, I made hundreds of lectures and always taking out specific parts of this. So I had a lecture about Alzheimer's or dementia and alcohol abuse, especially in the elderly. So as the Department of Psychiatry is again to hold this lecture in February, maybe we can focus, if there is interest of you, focus more on Alzheimer's disease and all the spectrum of what could lead to that. But I agree. So the influence of alcohol on the brain function and causing pseudodementia or even dementia is quite big. But I thought if I would have mentioned this today, I think we would sit here for another half an hour. And I wanted to avoid this. But I'm very grateful. And if you read about the history of Alois Alzheimer, At that time, the knowledge of medicine was quite small, and he was a specialist in two things. He was a specialist in psychiatry and pathology. That is the reason why the first Alzheimer's patient was not just his psychiatric patient, but he was also the specialist who did the examination of her brain after her death. Very interesting. Yes, and he got his PhD exactly about earwax, which is really good. Did you read the original?
Unfortunately, it was.
I can try to get. There is a very famous homepage where you can. It costs quite a lot. So this is where I got the copy of this original article from 1915. So they have copies of all famous old age German psychiatrists, whatever they wrote. And if you would like to, I can try to get a copy of his PhD about earwax. So thank you for listening. Have a great day and have a better weekend. Thank you.